Hi everyone, welcome back to Izzy Medicine, where I try to make tricky topics easier to digest. It would be nice if I could pronounce things. So at least I try to. Today we're diving into the fast-paced world of hyperthyroidism. And by fast, I mean hyperfast. And also, I should not go into comedy. So buckle up, grab your notes, and let's jump right in. Before we talk about things going haywire, let's refresh how the thyroid normally works. The thyroid is a gland that's in the front of the neck, and despite its small size, it plays a major role in controlling metabolism and produces two hormones, T4, which is thyroxine, and T3, which is triiodothyronine. These hormones basically tell the body how fast to use energy and help with regulating everything from heart rate to digestion. Now, how do we get those hormones in the first place? If you watched the hypothyroidism lecture, you probably remember that it starts in the brain. The hypothalamus releases TRH, or thyrotropin-releasing hormone, which makes the pituitary gland release TSH, which is thyroid-stimulating hormone. And TSH does exactly what it says. It stimulates the thyroid to produce T3 and T4. So once they're in the bloodstream, T3 and T4 loop back to the brain, and then they say, we're good. You can ease up on the TSH. So that's how the normal feedback loop works. And when it works, it's awesome. But in hyperthyroidism, the body gets flooded with too much T3 and T4. And suddenly it's like everything is in overdrive and hyperspeed. So now that we have the normal system down, let's tackle the causes of hyperthyroidism. So primary hyperthyroidism can arise in two main ways. One of the ways is hyperfunction, where the thyroid cranks too much T3 and T4 without control. And the second way involves follicular destruction, where the thyroid cells break down and then out of them, they flood the body with hormones. So regardless of the pathway, both lead to low TSH and high free T4. Think T4 is high, TSH is shy. I love it. I come up with the funniest things. Let's zoom in on one major cause of hyperfunction. So Graves' disease. This is the most common cause of hyperthyroidism. Here, the immune system produces thyroid-stimulating immunoglobulins, TSIs, and these antibodies mimic the action of TSH by binding to TSH receptors on the thyroid gland. And this causes the thyroid gland to be overstimulated. The stimulation causes the thyroid to produce excessive amounts of T3 and T4. And because the pituitary gland detects this abnormality of elevated T3 and T4 levels, it inherently in the feedback mechanism reduces TSH production, leading to low TSH levels. Despite the low TSH signal, like the brain's like, enough, thyroid, don't get stimulated, stop producing T3 and T4, the thyroid continues to overproduce hormones because of these TSI antibodies that are hyperactivating production. So for diagnosis purposes, to differentiate Graves from other forms of hyperthyroidism, it's possible to measure TSI levels, and that could be a useful tool. Next in line, we have toxic multinodular goiter, which is what it sounds like. It has a goiter with lots of nodules. So we have these nodules that are abnormal growths, and they're usually benign, and they're on the thyroid, and they start functioning independently. They just get a mind of their own. And they start producing thyroid hormones all by themselves without any regard to TSH levels. It's like they're working without permission. And they produce these hormones and they flood the system with T3 and T4. And again, the pituitary really is trying to work. So TSH levels decrease again to try to regulate this. But because the nodules are autonomous, like they're doing whatever they want on their own, and they don't listen, they keep producing high levels of thyroid hormones. Then we have a toxic adenoma, and that's like a single rogue nodule, just one troublemaker, and produces excessive thyroid hormones. And it's the same idea, and it's a little nodule that's ignoring the rules and pumping out T3 and T4 on its own. And again, the pituitary is really trying to work here, and TSH levels decrease in response. So finally, let's talk about thyroiditis. This is our destructive pathway, the non-overproduction pathway, but the destructive pathway. In thyroiditis, inflammation of the thyroid leads to the destruction of follicular cells. And when the follicular cells are destroyed, this causes a sudden release of all the stored hormones and a temporary phase of hyperthyroidism. We covered these in detail in our hypothyroidism lecture if you want to learn a little bit more. But we're focusing on 3 types. Postpartum thyroiditis after pregnancy, where there's destruction and there's a temporary elevation of T3 and T4 and then a return to normal. Subacute thyroiditis, which is often triggered by viral infections, where the destruction of follicular cells initially elevates levels, but then the thyroid often returns to normal function. And then there's Hashimoto's thyroiditis, which is autoimmune mediated destruction. And initially, again, because there's this flooding of T3 and T4, it can show hyperactivity and elevated hormones, but oftentimes results in permanent reduced thyroid function or hypothyroidism. These conditions basically show us how inflammation and cell destruction can temporarily increase hormone levels before setting into a different long-term pattern, be they normal or then long-term underfunctioning. So these were the primary hyperthyroidism causes, where we have elevated T3 and T4, and the pituitary responds and tries to decrease the TSH, so we have low TSH. Then we have secondary hyperthyroidism, and that's usually caused by pituitary microadenoma, a small subcentimeter benign tumor in the pituitary, and this tumor independently produces TSH. This extra TSH overstimulates the thyroid gland and causes it to produce high levels, both T3 and T4. And as a result, you'll see elevated T3 and T4 levels, but unlike in primary causes, you also see an elevated TSH because it's coming from the pituitary, from a tumor in the pituitary. And that's basically what secondary hyperthyroidism is. Now that we know a little bit about normal function and what causes abnormal function, let's talk about what happens to a patient with hyperthyroidism. What is like all this flooding of all these hormones doing to the patient? The symptoms can be pretty dramatic. So let's break down a few key ones. One of the standout symptoms of hyperthyroidism is goiter. And this is when the thyroid gland enlarges, and it can be a noticeable sign when the neck is swollen. The patient can come in, tell you that the neck is swollen, or an exam, you notice when you're examining that there's a swollen mass. In Graves' disease, the goiter forms because these autoimmune antibodies keep signaling the thyroid to produce more hormones than usual. This constant overstimulation makes the thyroid glands swell up because it's creating tissue to try to produce more and more hormones. In toxic multinodular goiter, we see these multiple nodules within the thyroid, and they're working overtime, producing excess hormones independently all on their own. And these nodules grow and become more active. They cause the thyroid to enlarge. And with the pituitary microadenoma, weirdly enough, the stimulation is a little bit different. This tiny pituitary tumor pumps out extra TSH, and the overload of TSH prompts the thyroid to swell up because it's receiving TSH nonstop, which is telling the thyroid to produce more and more hormone. The thyroid swells up, leading to a goiter. So in addition to a goiter, there's more symptoms. There's always more symptoms with hyperthyroidism. Our patient may also notice feeling unusually warm and also complain of losing weight, even though their appetite is increased. So here's how our puzzle pieces connect here. Excess T3 and T4 increase the body's metabolism by boosting cellular activity, which directly impacts energy use. This causes sodium-potassium pumps in the cell membrane to work harder. These pumps use ATP as they're working. So now here's the twist. Producing ATP generates heat as a byproduct. So with those pumps working overtime, more ATP is being made because more energy is being made, but which means that more heat is produced. So that's why the patient feels warmer and is oftentimes sweating as well. So if the patient comes in and says like, I'm hot, I'm sweaty, I don't know why it's happening, think hyperthyroidism. The metabolic boost also burns through energy stores quickly. So even if patients maintain or increase their calorie intake, increased metabolism leads to higher ATP consumption, meaning more energy is spent just for routine processes. And this extra energy expenditure results in weight loss as the body burns fat and sometimes muscle. And so we have a patient that's hot and losing weight, even though they're eating regularly as they were before. And other symptoms that can happen is insomnia, for example, anxiety, heightened reflexes. And what happens there, the T3 and T4 affect the nervous system and make it run into overdrive. The thyroid hormones significantly boost the body's metabolism, and they keep energy levels high even when it's time to sleep. And this overactivity makes it harder for patients to wind down, leaving them restless and struggling to get restful sleep. The nervous system is also highly stimulated by the extra T3, T4, and that leads to symptoms of anxiety. Patients may feel constantly on edge, restless, jittery, even panicky sometimes because their nervous system is heightened and almost in like a hyper alert state. And with the system being all amped up like this, nerve transmission and muscle response times are accelerated too, which makes reflexes quicker and more pronounced. So when we test for reflexes, they tend to be brisk. And it's because of this heightened neuromuscular response. In the same category, but a little bit different, patients sometimes experience palpitations when they have hyperthyroidism, or like a sensation that their heart is racing. And this happens because high levels of thyroid hormones, T3 and T4, directly impact the heart's function by increasing the sensitivity to sympathetic nervous system signals. Here's how it works, since I like when we understand things. So elevated T3 and T4 levels increase the number of beta adrenergic receptors in the heart cells. These receptors respond to adrenaline and similar hormones. And when they're upregulated, when you have more, the heart becomes extra responsive to adrenaline. And as a result, the heart starts to beat faster and more forcefully. And remember when we joked about hyperfast? Your patient's heart didn't find that funny. Really, comedy. No going to the comedy cellar for me. This increased force of contraction, called contractility, means that the heart is pumping with more strength than usual, which also raises systolic blood pressure. So each heartbeat not only comes quicker, but also with more force, and patients may feel palpitations, dizziness, or chest pain as their heart is essentially just working overtime. Hyperthyroidism often also disrupts the menstrual cycle due to its effects on hormones. So this is how that works. High levels of thyroid hormones, T3 and T4, cause the liver to produce more of a protein called sex hormone binding globulin, or SHBG. And SHBG binds to sex hormones such as estrogen and progesterone, which affects how much of these hormones are freely available in the bloodstream. So it's basically just binding things that the body needs for work. And when these SHBG levels rise, more estrogen and progesterone are bound up, and meaning less accessible for the body to use. And there happens a dysregulation of the menstrual cycle. And active estrogen and progesterone not being as available may cause irregular cycles, periods that are lighter, or are missed altogether. So that's another symptom that a patient can complain of. So if we're looking at somebody that's restless, having insomnia, having some like feeling overheated, having irregular periods, think about hyperthyroidism. Diarrhea is another common symptom of hyperthyroidism, and it's all tied to how the elevated T3 and T4 hormone affect the entire body. And of course, it affects the digestive system as well. Why would it skip it, right? When these hormone levels are high, they increase gastrointestinal motility, or how quickly the food moves through the intestines. And with the intestines speeding up, food moves too quickly through the digestive tract, and it doesn't give enough time for water to properly absorb. And it basically comes out, and you get this liquidy stool with water not being reabsorbed, and you get diarrhea. Two other distinctive signs that versus symptoms, which I guess palpitations, you can do an EKG and you can see that somebody has a rapid heart rate, so that can also be a sign in addition to a symptom. But two other distinctive signs you may see are exophthalmos, which the eyes are protruding, and pretibial swelling, which is swelling over the shins in the kind of knee shin area, both of which are linked to an inflammatory process and fluid buildup. So let's start with exophthalmos, understanding why it happens. When thyroid hormone levels are up, they stimulate the production of glycosaminoglycans, or GAGs, and these molecules attract water. These GAGs accumulate in the tissue and muscle behind the eyes, and they pull in water, and they cause swelling in that area, and that buildup of fluid pushes the eye forward, and it results in that characteristic eye protrusion called exophthalmos. What also happens when T3 and T4 levels are elevated, it causes fat to accumulate in the orbital cavity, which further pushes the eye forward. And on top of that, the inflammation can affect the nerves around the eyes, increasing the bulging, and actually also potentially causing discomfort, as if the bulging alone wasn't uncomfortable enough. Pretibial swelling is similar to its mechanism. The gags don't just affect the tissue behind the eyes, they can also build up in the skin over the shins. When they attract water there, it leads to fluid accumulation and like a swollen, thickened appearance on the lower legs. Now that we've discussed all of these signs, symptoms, issues, let's talk about the big one. What happens when all of this kind of accelerates and then we get what's called a thyroid storm? Excuse me. So a thyroid storm is a life-threatening complication of hyperthyroidism, and it's essentially an extreme and sudden intensification of these hyperthyroid symptoms that we talked about. So what happens is, imagine you have a patient with hyperthyroidism and it's not well managed and they're just walking around with all these symptoms, and suddenly they face a trigger, and it could be infection, trauma, surgery. This trigger causes thyroid hormones to surge, and the symptoms dramatically worsen in a very short period. And what happens, it's like every system in the body is pushed into severe overdrive. The patient can spike high fevers, often over 104. Their heart rate soars, putting intense strain on the cardiovascular system. It's called tachycardia, and it can even progress to dangerous arrhythmias if it's not controlled. And additionally, the patient may become severely agitated or confused and having an altered mental status because of the increased impact on the central nervous system. And this is a true medical emergency. Treatment must focus quickly on bringing the high thyroid hormone levels down and stabilizing the body systems, like lowering temperature and lowering heart rate, and preventing complications. To diagnose hyperthyroidism, we start with the basic blood tests, and we start with checking thyroid hormone levels. Specifically, we check free T4, and we also check the TSH, the thyroid stimulating hormone. So here's what the results can tell us. Primary hyperthyroidism, if free T4 is high and TSH is low, typically points to primary hyperthyroidism. If we suspect Graves' disease anywhere in the process, like we have a goiter and that's big, then what we can do is we can follow up with TSH receptor antibodies, TRA antibodies, or TSI, thyroid stimulating immunoglobulin test. And if it's positive for antibodies, it confirms Graves' disease as the cause. If we have a negative antibodies, or we have a low suspicion, like there's not a big goiter, and we can perform a thyroid uptake scan. So this scan helps us visualize whether the gland is diffusely overactive, or can show us if there are nodules that might indicate a toxic adenoma or multinodular goiter as the cause. And in secondary hyperthyroidism, what happens is both T4 and TSH are elevated. We consider secondary. And that's when the pituitary gland is driving the increase in thyroid hormones. And this is less common and suggests a pituitary issue. And there we can perform a pituitary MRI and see if there's a TSH secreting microadenoma. And through this approach, with starting with TSH and free T4, and if needed, like adding antibody tests or scans or imaging, we can pinpoint the type and the cause of hyperthyroidism, and kind of like part of the puzzle pieces, and guides us more to the accurate diagnosis. Now, to wrap up, let's kind of quickly walk through treatment options. And treatment options depend on, whether we're managing it acutely or whether we're managing a chronic hyperthyroidism issue. So we have several options to continue with medications and also supportive measures. So for medications for just regular hyperthyroidism, for many cases, start with medications that directly reduce thyroid hormone production. The primary drugs here are methimazole and PTU. These medications work by blocking thyroid peroxidase, and that's the enzyme that's essential for producing thyroid hormones. So when we block it, there's a reduction. PTU has an added benefit of preventing T4 from converting into T3, so that's an additional benefit. If we have medications and it's not sufficiently controlling thyroid function, or we want a permanent solution, we can use radioactive iodine ablation. And this involves administering radioactive iodine, and it selectively targets and destroys thyroid tissue, and it reduces hormone production. A lot of times after this treatment, we go into hypothyroidism, and we need to maintain hypothyroidism treatment. If we have the patient that's restless, having a racing heart, having anxiety because of this excess hormone production, we have to manage the symptoms if they're having palpitations. And oftentimes we give beta blockers like propranolol to help the symptoms of tremors, anxiety, heart rate, and the symptoms that affect the nervous system. That's kind of supportive measures. And for thyroid storm, so the treatment has to be rapid and aggressive. So we give high dose PTU because that not only stops the production, it also prevents the conversion of from T4 to T3. Lugol's iodine solution to trigger the Wolff-Chakoff effect. Dexamethasone to reduce inflammation and block the conversion of T4 to T3. That's an added benefit. And then we have supportive care that includes cooling measures, IV fluids, electrolyte management, and respiratory support. And with that, we've covered, I think, all the essentials of hyperthyroidism treatment, from managing the routine to the critical. And I hope this breakdown helped solidify your understanding and that you were at least a little bit entertained by my attempts at being funny. And a great job following the puzzle pieces. And if you like it, don't forget to hit like and subscribe and, hit the notification bell, whatever young people do on YouTube. And thank you so much for watching, and stay curious and keep learning. Until next time, bye.